screen on the display. So basically, after a very interesting session, I'll be talking about nerve monitoring and especially continuous nerve monitoring. And the morning sessions, the instructional course and the talks initially have made my life a little easier. So now expanding on that, let's talk about continuous nerve monitoring. So it's basically hearing continuously what the nerve has to say. So why nerve monitoring? And we have tried answering this question. The debate is still on, but all of us sort of agree that whenever you're doing a redo case or a recurrent case or a hard case, it's an adjunct which will help you preserve the nerve better than just the visual identification of the nerve. And so that brings us to this slide. And there is enough data to say that non-visualization of the nerve is definitely poorer than the visualization of the nerve, versus there is equivocal data to say that visualization with intermittent nerve monitoring may or may not be better than just anatomical visualization of the nerve, but it's not inferior. But I'll bring in another aspect, another question to it. That is visualization with continuous nerve monitoring better over intermittent, or are they very similar? That's the point of it. Yeah. So that's basically the whole premise of the talk, that does continuous nerve monitoring has any benefit. So let's basically compare the three modalities: anatomical visualization, the intermittent nerve monitoring, and the continuous nerve monitoring. So anatomical visualization is paramount. It is gold standard. There is no replacing anatomical visualization of the recurrent laryngeal nerve during thyroidectomies. But the biggest problem with anatomical localization is that anatomical continuity does not always mean functional continuity. So you can have an anatomical nerve which is non-functional, and that's the problem which is there in thyroidectomies, which does lead to vocal cord palsies, either temporary or permanent in the post-operative period. And this, as thyroid surgeons, we all have faced. That brings us to the next part, which is the intermittent nerve monitor. It is definitely an added adjunct to the anatomical localization. It helps in nerve identification function and does help in identifying the site of injury. But there are two problems with intermittent nerve monitor: that between two stimuli of the nerve, if there is an injury, you will not come to know about it, and it does not provide opportunity to the surgeon to do anything to reverse this injury. So it can be used as a nerve locator, a nerve identifier. It gives you great post-procedural prognostication based on the functionality and your amplitudes on the nerve monitor, but it does not give you an opportunity to prevent nerve injury from happening. So that brings us to continuous nerve monitoring. Is it really a better adjunct? Let's see. It enables a real-time analysis of your vagal RLN axis. It can identify impending nerve injury, so it does provide you a window of opportunity to do something different and prevent an injury from going into paralysis or paresis and leading to a loss of signal. So it is a great nerve locator and identifier, but it also is a great intraoperative monitor. So it may bring down rates of vocal cord palsy, maybe temporary, maybe permanent. Now, coming to principle and methodology, it is just a real-time, uninterrupted surveillance of the nerves, both vagus and recurrent laryngeal nerve, throughout the surgery. So the continuous nerve monitoring basically means constant nature of monitoring of the vagal RLN axis, and it employs an implantable stimulator on the vagus nerve. Different companies make different stimulators. The Medtronic comes with an APS, the IONM comes with a Delta, so each company has its own names. The principle is the same, that you put this implantable electrode over the vagus, which continuously stimulates the vagus at a fixed current and a fixed frequency during the whole case. And the frequency can be changed based on your requirements. The default setting is a 1 milliampere and 1 every 6 seconds of stimulation. So this is important, and I'll come to this fact separately. So what you do is basically you open the carotid sheath, you identify the vagus, you free 360 degrees, and you basically put this electrode around the vagus nerve. And once you do, there is a continuous nerve monitoring which starts happening. Just a minute. So basically what you get on your monitor is two lines, one for the latency, one for the amplitude, and then there is something known as combined events and high risk features. We'll come to that subsequently. But this is basically the monitoring of the recurrent and the vagus that's happening continuously. So coming to the next point, that how are these very different? Basically, intermittent nerve monitoring is based on the principle of surgeon-defined periodic intervals. The surgeon defines and picks up the stimulator to check for the nerve integrity and function whenever he or she feels they need to check the axis. Some do it only at the start of the surgery and end of the surgery. Some do it only at the end of the surgery. We do it more frequently, and as surgeons, we all know that there are certain areas of thyroidectomy where you might feel that there is a chance you will injure the nerve and you'll pick up the stimulator more frequently. But the problem is that surgeons, we are not great predictors where nerve injuries can happen. If that would have been the case, the vocal cord palsy rates would have been zero. But even with all the experience, there is a chance we may injure the nerve unknowingly. And that is where the continuous nerve monitor comes into picture, that it gives you a feedback going on continuously behind the surgeon's back and tells the surgeon if there is something wrong going on to the nerve, which is not clinically detectable as yet. We all know that majority of the nerve injuries are tractional, and 60% of these injuries happen at ligaments of Berry. It can be a facial band, it can be a vascular band, and whenever you're pulling the thyroid out, inadvertently you may lead to strangulation or traction injuries on the recurrent laryngeal nerve, which are not identifiable by naked eye. And that's the basic benefit. So continuous nerve monitor provides you a window of opportunity whenever there is a chance that there is some strangulation or traction on the nerve. So this brings us about the concept of combined events. So this is what the machine tells us, that there is a combined event which can lead to palsy and we need to change our surgical technique. So that's again a little bit of data across the globe which showed that continuous nerve monitor has high predictability to tell about post-operative function, and in Schneider series the rates of permanent cord palsy went down to zero when they compared continuous with intermittent. So just a small data on that. Now coming to the events, so there are three scenarios which can happen. One is the amplitude changes but the latency doesn't. The other is the latency changes, the amplitude doesn't. And with these early events, usually the vocal cord function remains intact post-operatively. Then what we need to understand is the combined events. The combined events can be mild or severe. So combined event is both your amplitude and latency changes. In mild, it would be less than 50% of amplitude decrease from the baseline, and a latency which goes about 5 to 10% of the baseline. If you have these, this is basically the first warning that the machine gives you to change your surgical technique. So the moment you go into mild combined events, the machine goes yellow. It tells you something is not working fine. You need to change your traction, your retraction, your exposure, so that these do not convert into severe events. And this is where there is a window of opportunity for the surgeon to prevent nerve palsy. Next comes the severe combined events, which by the international group, basically the definition is the amplitude has to go less than 50% of the baseline. The latency has to go more than 10% of the baseline. And if this happens, this is where there is a real risk of nerve injury. And this combined event, if goes on for more than 40 seconds, there is a very high chance you will land up with something known as LOS, which is loss of signal, which technically is defined as an amplitude of less than 100 microvolts and basically correlates directly with post-operative vocal cord palsy. So this is where you really need to make sure that the severe combined event doesn't get converted into a loss of signal thing. And so this is basically a busy chart which they said, and this is the summary of all the changes, that combinations that we can have. And usually you want to make sure that combined events do not get converted into a loss of signal. And this is just an example of the continuous nerve monitoring clinical utility. We did show this video in the morning as well. We had this band of fibrovascular tissue which was crossing over the recurrent laryngeal nerve. Anatomically, the nerve is very well seen and preserved, but with each traction there was strangulation of the nerve which got picked up by the nerve monitor, which gave us an indication that there was increase in latency and amplitude. And subsequently, when the band was released, there was improvement in both amplitude and latency, and thus a potential injury to the vocal cord was prevented in such a case. So If it's so great, what is the problem? Why don't we use it in every patient? There are certain concerns which are associated with continuous nerve monitoring. And basically, there are 4 major concerns. The first concern is to do with the electrode which needs to be put on the vagus. So there are concerns that while we are freeing the vagus, can there be a tractional injury because of the electrode, or can there be a devascularization injury to the vagus, or can we just injure the vagus iatrogenically, leading to palsy in the post-op? The second commoner concern is because you are stimulating the vagus and it's a parasympathetic nerve and a mixed nerve, can you have a hemodynamic and autonomic disturbances in these patients? And the third is because you are constantly irritating the nerve or stimulating the nerve, can it lead to nerve fatigue and palsy in itself? Let's see all of them one by one. So basically, injury to the vagus, this is again from an animal model where they put on an electrode, pushed it, yanked it with all the force that they can. What they saw was the electrodes are very soft, they come out easily. Even if it leads to palsy, the palsy is temporary and the cord usually improves within a month. So again, the electrode usually doesn't cause any tractional or direct injury to the vagus. Now, the second thing is the hemodynamic and the autonomic disturbance. Basic physiology, vagus is basically composed of 3 types of fibers, A, B, and C. C's are the fibers which activate the autonomic nervous system, but they only get activated at supra-threshold current stimuli of more than 2 milliamperes and a frequency of 30 hertz. So what we use in continuous nerve monitoring, usually the default setting is 1 milliampere and 1 stimuli per 6 seconds. Autonomic activation and heart rate variability never happens. So it's pretty safe, and there is data that even in AV block patients, children, it is pretty safe. The third is nerve fatigue and injury. Again, at the settings that we use, which is 1 milliampere and 10 microseconds of 100 microsecond of exposure, nerve injury never happens. You basically compare it to the settings where nerve injury is seen, it's remarkably different. Also, about 6 hours or 10,000 stimuli of vagus continuously did not lead to any nerve fatigue and vocal cord palsy. So it's pretty safe. Now, just a brief about the newer advances, because again, as there is concern that if you identify and isolate vagus, you can injure it. There is something known as laryngeal adductor reflex based continuous nerve monitoring, where the electrode is placed on the supraglottic mucosa. So no vagal stimulation and vagal identification and exposure needs to be done. And that supraglottic stimulation basically utilizes a primitive reflex of the brainstem and continuously activates the glottis and gives us the feedback. Now, there are sometimes concerns about endoscopic or robotic thyroidectomies because you don't have the exposure to the vagus. And can we do continuous nerve monitoring in these patients? We can, but this is still a little bit in infancy where they use transcutaneous or transcranial stimuli. But again, the results have not been reproducible, but the most promising is the laryngeal adductor reflex based continuous nerve monitoring. So just to conclude, that's my last slide, that it's no longer a niche tool. It is a mature and a safe adjunct for thyroidectomies. It should form a part of our armamentarium when we are doing thyroidectomies. It provides you a real window of opportunity to prevent any injury to vagus and gives surgeon a feedback to change what they are doing to prevent post-operative palsies. It has a reliable prognostic feedback, and it is a safe adjunct to use. So far the safety profile of continuous monitoring has been equally good. So thank you.